First of all, I need to introduce myself. For today's presentation, I'm the medical director of a pharmaceutical company called Trio Medicines Limited. This is my indulgence. My daytime job is being the medical and managing director of a clinical research organisation based in London, which does the early clinical trials of potential new medicines for pharmaceutical companies worldwide. I started the company in 1993, since when we've done over 740 clinical trials. Most of those are potential new medicines. Many of them are the first time in man, and there are now 240 of us, and we have extensive premises. We moved into in 2008. This was in fact formerly the headquarters of Guinness, which we acquired and converted into a research unit. And we can take, do the development of a potential new medicine, which in the trade is known as a terrible name, an investigational medicinal product, which gets abbreviated to IMP. We can take it from design all the way through to publishing into scientific journals, and setting up the studies, the big studies which are required in patients. Before I move on to talk about Gastric, I feel it's necessary to comment on what I've heard today, and it's been a very fascinating day. Of course, what you're trying to do with B12 is you're playing catch-up drug development 50 years too late. And until you do these trials, you'll be coming back here every year and with anecdotal comments, many of which I accept are real, of benefit from injections, and you really do need to tackle this as a new project. I mean, if this were coming through to my unit now, we would do single ascending dose studies, first in healthy subjects, then multiple ascending dose studies. We would do pharmacokinetics, that's what happens to the B12 in the body, and then pharmacodynamics, what does B12 do to the body. We would look for biomarkers, many of those have been mentioned. We would look at probably radio-labeled B12, where does it go, how long does it last, and then we would proceed to patient studies. We'd have a reasonable evidence of the sort of dose. And then you would, believe it or not, you would have to do placebo-controlled trials. You could sort out the dosage, you would find the dose, you would have to find the doses interval. You really don't know whether it's every day or every 3 months. You don't know whether you need a depot preparation, which is a fancy name for one with a long duration of action. And there's an enormous amount to be done. The problem is, Martin told me last night over dinner that each injection costs 27p. So no pharmaceutical companies would want to investigate in a development program when at the end of it the reward is a product worth 27p per injection. You'd have to come up with some super duper formulation, and the other problem is, if it weren't a new product, is it an IMP? Is it regulated by the Medicines and Healthcare Product Regulatory Agency, or is it a foodstuff regulated by the Food Standards Agency? Or if you give it as a long-acting depot preparation, is it a device? I think the MHRA would probably call it a device, and then they would regulate it. You've got to do toxicology. It's a lot of work. Now, I'm not. I have to defend the concept that it takes years and years to do research. You need to do it in a clinical trial factory like this. We're open 24/7 throughout the year, just like any other hospital, wholly dedicated to research, and it's highly bureaucratic. You have to understand the rules, and you can. Everything that you need to do, we can do, but it would cost money. What you need to do, you need to find someone like Bill Gates or J.K. Rowling and hope that they get pernicious anemia. and fund your program. On the other hand, it strikes me as if it's crying out for investment from within the health service. But unfortunately, the health service is not very good at doing clinical trials. It needs to be done by professionals like me who do it for a living. We're the commercial sector, and we do it for pharmaceutical companies, and there has to be a profit at the end of it. Anyway, that's my summary of the day's presentations, but I've learnt a lot, and thank you very much. So I move on now to my real reason for being here, which is about Gastric. Now you all know that vitamin B12 in food combines with the intrinsic factor to absorb vitamin B12 to form red blood cells, and that's in the healthy stomach. In the pernicious anemia stomach, and it all starts, the villain of the piece is autoimmune chronic atrophic gastritis, as you've heard. You don't make intrinsic factor, although there are cases, patients that I'm going to mention, who seem to make intrinsic factor and don't and get the tumours that I'm going to mention, and you get these malformed cells. But as you've also heard, I've learnt today that you might have normal cells and still have pernicious anemia. Now on to gastrin. When one eats food, it stimulates cells in the lining of the stomach called G cells to secrete a substance, you can't see that very well, called gastrin. Gastrin is a hormone. A hormone is a chemical messenger, if you like. It's carried in the bloodstream to other parts of the body where it exerts its effect. Insulin is a hormone. Adrenaline is a hormone. You can't. You hear it every day on the news. Talk about an adrenaline rush. So gastrin is carried to other cells in the lining of the stomach called ECL cells, which possess receptors which gastrin stimulates. It releases a chemical mediator, histamine. You've all experienced histamine. If you put your hand in a stinging nettle and you get a red blurb and it itches like mad and red, that's mostly due to histamine. Histamine stimulates the parietal cell to make acid, and as food moves out of the stomach into the duodenum, it switches on another hormone called somatostatin, which feeds back and switches off gastrin. Now, in people with chronic immune gastritis, the body makes these antibodies against the parietal cell. There's no acid. Somatostatin is not switched off, and so gastrin is uncontrolled. And if I get this right, I should be able to get a big increase in gastrin. And this is data taken from healthy subjects and patients with pernicious anemia. In the healthy subject, acid in the stomach goes up and down throughout the day as you eat: breakfast, coffee, lunch, tea, dinner, nightcap. And you get these big swings in acid which come back more or less to normal in between, whereas patients with pernicious anemia in this study, there weren't that very many of them, but they make no acid whatsoever. So they're all these patients would all have very high amounts of, I would expect them to have very high amounts of gastrin in their blood, which is exactly the case. This is gastrin in the normals. It fluctuates. It drives the acid, it's the driver. This is pernicious anemia patients. Note the scale here, 0 to 40 for normals, 250 to 650 for patients with pernicious anemia. So pernicious anemia patients, genuine pernicious anemia patients, and I use that word carefully because not everybody who is deficient in B12, as you've heard repeatedly today, has pernicious anemia. Patients with pernicious anemia will have very high levels of gastrin in their blood. Now, what do we do about it? Well, there are some doctors who say nothing. There are others who think you should assess patients regularly with this procedure, gastroscopy. Martin, I think, refers to this as an upper downer. Is that right? Are you there, Martin? This pencil-thin tube with a light at the end. It's like a telescope, and you see a picture of the stomach on the screen, and you can see what's inside of the lining of the stomach. It's called gastroscopy, and it's being done in our unit, and this doctor's looking at the screen to decide what's going on in the stomach. Now, in patients with pernicious anemia, some have these tumours. This is a single tumour. It's called neuroendocrine tumour, or NET for short. They're usually multiple, but this is just one large one. The stomach juice is acid-free. It's just like water, because this stomach doesn't make any acid. And if you know from your days of O-level chemistry, a bit of litmus paper in this, dipped in this gastric juice would show there was no acid. These tumours, according to the scientific literature, are said to occur in 5% of patients, but to be truthful, we really don't know the true incidence. I think it's much higher than that, but 5% is the sort of what you will read. They grow from these ECL cells because gastrin stimulates the receptors on them. And does it matter? Well, it matters because in some patients they spread outside of the tumour. They go to the liver and to other local glands. And although the prognosis is good, sometimes patients undergo surgery. And how many spread? Well, again, the estimate in the literature is 5%. So it's 5% of 5%. So it's a small number spread. But there is also evidence that patients with pernicious anemia or chronic atrophic gastritis also have an increased risk, and that varies between 2 and 7% depending on which scientific paper you read, of another type of tumour called a gastric endocarcinoma, which is quite unrelated by the time it presents to the ECL cell, but there are those doctors who believe that even those come from the ECL cell. So there is an increased risk, but everything we do nowadays carries an increased risk. And now the recommended treatment for gastric nets in patients with pernicious anemia or atrophic gastritis is regular gastroscopy. To map and biopsy the tumours, you need to look at them under the microscope. Are they really nets? And if there are lots of small ones, and there often are, then you might do nothing but carry on with regular gastroscopy. If there are any concerns, and concerns usually means big tumours, more than a centimetre, or some say 2 centimetres, and any evidence that they're invading the lining of the stomach, then it needs more than removing them, which you can do with that gastroscope, clipping them. It's called polypectomy, or you can remove the part of the stomach that makes the gastrin. That doesn't always work, and it carries the risk of morbidity and mortality, of course, from surgery. So the ideal treatment, I think, is really a medicine to block the effects of the gastrin, because these tumours are gastrin-driven. And in my view, there's an unmet need. Now, the gold standard of gastrin antagonists is this one. It's been around some years. Many pharmaceutical companies have tried to make gastrin antagonists and failed. They're not well absorbed, they're not selective enough, and they're not specific, and so on, and they didn't really feel at the time there was a need. But I think things have changed. I think there really is a big need for a gastrin antagonist, and for the chemists in the audience, that's the structure. It's a simple benzodiazepine derivative. So through TRIO, I set up studies in 2 centres, one with Mark Pritchard's group in Liverpool, another one with a group in Trondheim in Norway, and they had 8 patients per centre, making 16 in all, and we dosed patients for 12 weeks with 12 weeks recovery. Now we could only dose for 12 weeks because that's all the toxicology cover we had with this particular molecule. Now these are known as Whisker plots. Sorry for, but I can take you through them. The top whisker is the maximum number of tumours in any one subject. So one subject had 30 and the least number was 5 and the average was about 10. But you can see over the 6 to 12 months the average goes down and the range narrows, and these are statistically significant. But when it stopped for 12 weeks, there's some recovery, not complete, but there is some. And the same is for the largest tumour, which they measure with the end of the gastroscope, and you can see that that too is going down, and recovery on stopping treatment. And a biomarker called chromogranin A, or CGA, is very increased in these patients because CGA comes from the ECL cell, and at the first assessment at 3 weeks it slapped right down in the normal range, and when you stop treatment it recovers, although not completely. Now our aim was to eradicate these tumours, at least that was my aim. I thought that we might achieve that with much longer treatment. And I managed to persuade the MHRA to allow us to dose patients for 12 years, these 8 patients for 12 months, without doing the additional toxicology, which is a great saving in money. And in Norway, they wouldn't allow patients but under that rule, but they did allow me to treat them on a compassionate treatment basis, and that there are that's one method of testing medicines in humans. So we proceeded to a longer study. Incidentally, these are the tumours that you see in the stomach. These are from the Liverpool group before, in the very first patient. And I remember talking to the that time he certainly seemed young to me. He was doing his PhD, and I said to him, I think your claim to fame later in life will be you're the first doctor that's tested a gastrin antagonist in these tumours, and when you look down the gastroscope over 12 weeks they'll all have gone. Well, that proved to be optimistic, but that you can see they are smaller. And I was delighted when he called me after the midway gastroscopy, and to his amazement, he seemed amazed, at least he did to me, and said, it's worked, you were right. But as I said, we needed to treat them for longer. It took a while to get their approval, and in the meantime, patients were off a mean of 14 months, and 5 of them were, 3 of them weren't prepared to go on. That they didn't like the gastroscopy all that much, not regularly. So we got 13 of them, and in the time they were off treatment, you can see there's a big increase. It's almost doubled. Same for the largest tumour, and their chromogranin A comes back to normal. So we proceeded to the 52-week or 12-month study, and the average now is around about 12, but you can see this progressive reduction. The whisker disappears off the bottom. That's because for 6 of them, about 6 of them, the tumours were completely eradicated, 6 out of 13, so nearly half of them. The same for the size of the largest one. Those that remained were much smaller, and chromogranin A came down and stayed down for the whole of the 12 months. Now, in Liverpool, they also did some special tests to try to find out biomarkers, because what I want to know is, are there ways of avoiding gastroscopy? It's expensive to the NHS, it's not done very often, and a simple blood test might be useful. And I'm pleased to say that Liverpool found that a substance called MRI, microRNA treble 2, which controls a number of genes, that the levels in patients, with the 13 patients, were much higher in the blood compared with normal subjects, and nitazepide reduced the levels below the normal range, actually, although, of course, these are different groups of subjects, and one has to be very careful about comparing them. So it looked as if we had two biomarkers here, chromogranin A and Anaemia treble 2. So in conclusions of this work, in patients with chronic atrophic gastritis with or without pernicious anemia, and of the 16 patients, only 10 were on B12, so they didn't all have pernicious anemia, even though they had the atrophic gastritis. We can say that a gastrin blocker can eradicate multiple tumours, or at least reduce their number and size, and it may reduce their potential to spread, which is what we really want. We want to not necessarily get rid of them all, but we want to make them harmless and to block the excessive gastrin, which those of you with pernicious anemia will have swimming around in your blood. That's true pernicious anemia. In many ways, it's a real test of the condition, and we've not heard that mentioned today. There's been much emphasis on B12 and how you measure it, but measuring gastrin is also a good test, although even that too doesn't always necessarily give you a complete answer. So it's an alternative, I say it's an alternative to regular gastroscopy and surgery, and I'll show in a moment a survey carried out by Martin Hooper and Mark Pritchard in PAS patients. And treatment's got to be continuous because the tumours will grow, but we don't know whether that could be every other day, every week, a much smaller dose. We need to do the trials to find out. And we can measure these biomarkers in the blood, and are they a substitute for gastroscopy? And it was safe and well tolerated. We haven't yet identified a treatment-related side effect, but it merits a clinical trial in many more patients, and that has to be placebo-controlled for the simple reason that many of these assessments are subjective. It's the gastroscopist looking down and counting tumours, and if everybody's on active treatment, there's a tendency or an incentive to improve the results and not count them all. So I want to do two trials, and for these I need your help. Gastric nets in patients with pernicious anemia or chronic atrophic gastritis are rare tumours. They're classified as an orphan disease. Nitazepide and a successor, which I will be working on, not on nitazepide itself, is an orphan drug recognised in Europe and the USA. It takes a lot of effort to get that out at the regulators. And I've talked to the European Medicines Agency down in Canary Wharf, and because it's a rare condition, they will accept one study, and I've suggested 220 patients with the 4:1 ratio, four gastrin blocker, one placebo, and followed up for a year with a 6-month recovery. And to do this study, I need the help of the Pernicious Anemia Society. I've already talked to Martin. There is a sister foundation called the Neuro Endocrine Tumor Foundation. I've talked to them. They're keen to participate. There are organisations among doctors which look after these tumours. That's the United Kingdom and Ireland Neuroendocrine Tumor Society and the European NETS group, and of course my little company Trio. This is an old map, but there are now 35, I think, centres of excellence, ENETs, throughout Europe. To find 220 patients, we're going to have to go to a lot of centres, but I've already had buy-in from the ENETS organisation, so I'm hopeful that we can find them. So that's the first study I want to do. I've already met one person tonight, or this afternoon, with gastric carcinoids. He's been very fortunate. He's had the full works, gastroscopy, biopsy, and lots of fancy tests, and he really does have these tumours, and therefore he really does have pernicious anemia. The other study I want to do is to see whether we can use a blood test to replace gastroscopy. Now, this work was done by Mark Pritchard with Martin Hooper, and it was an online survey of 560 members of a Pernicious Anemia Society, and they were asked to report their experience. Now, this is information collected over the internet, and it's reports, and these sorts of things are notoriously unreliable, I have to say, but they're the best you can do. And only 131, 23% said they'd had a gastroscopy at diagnosis. 180 had had 108, 19% had had a biopsy of their stomach lining to confirm whether or not they did have NETs. Only 30 were said to have atrophic gastritis. That's a withering of the lining of the stomach. Now that's remarkable, because all these patients, if they have true pernicious anemia, would have had chronic atrophic gastritis. You don't necessarily see it down the gastroscope. You have to biopsy it and study the histology, the microscopy. Only one had a gastric net, so you can do the sums for yourself. The incidence in this case was 1 out of 131, so that puts into perspective the information I was giving you. None had gastric cancer, and only 13 were followed up with regular surveillance. So what other study I would like to do is in patients with pernicious anemia. Now, we will have to use very strict criteria for pernicious anemia and exclude patients who just have B12 deficiency. Now, I don't know how many people in this room really have pernicious anemia. Some cynics who write in the literature would say it's as low as 20%, and that the others are receiving B12 for a B12 deficiency unrelated to pernicious anemia and chronic atrophic gastritis, but that's a debate which we could have and spend a lot of time going through. So I want to 100 volunteers with pernicious anemia confirmed as best we can without gastroscopy, compared with 100 healthy subjects, age and sex matched controls, 1 blood samples to measure these biomarkers, and then a short trial of our gastrin blocker to see whether we can reduce them within the normal range. In other words, if I can hedge back now, I hope that the ones with true pernicious anemia will have raised levels, and that we can suppress them. And by doing so, we prevent the spread, the metastases, the nasty side effect of gastrin. And we can also measure chromogranin A. So I need your help for that. I suggest that I come back here next year to do the last one. I really only need a blood test. I would bring some of my physician colleagues and nurses, and I would have a hotel room here with a nice bed and a barley sugar afterwards. I ask you to donate 1 blood sample, from which we can get a lot of useful information, and I will collect the 100 healthy subjects from my very big panel. I have a panel of something like 50,000 healthy subjects who take part in our clinical trials. So please volunteer. I need to thank a lot of people, the Liverpool group, particularly Mark Pritchard, the Trondheim group, and my group here. It takes a lot of people to put together these clinical trials. So if you have any questions, please ask. If you want to volunteer, there's a free phone number. There's my website. I think Martin's going to put all these presentations on the PAS website. So please do volunteer, even if it's only to give a blood sample. I'm afraid I can't arrange for you to have a gastroscopy. In theory, there's 100 of you here. If you all have true pernicious anemia, 5 of you will have, an average of 5 of you will have gastric nets. I found 1, Are the other 4 willing to put up their hand? 2. So we got 3. So 3, and of course, not everybody here does have PAS. They're helpers or friends or people like me that we think we're healthy. The definition of a healthy person is someone that's never been investigated. So don't be put off by what I say. Anyway, thank you for listening.
Thank you very much, Malcolm. Do you have one question?
Is there any evidence that taking PPIs for 16, 18 years, is there any sort of evidence based on the fact that that kind of keeps Barrett's esophagus at bay and prevents stomach cancer?
Okay, well, thank you for asking that question. First of all, proton pump inhibitors are usually used these days to treat a reflux, acid reflux into the gullet, or GORD as it's called. Ulcers in the stomach are due to a bacteria, H. pylori, and you treat that with an antibiotic. Now, long-term use of proton pump inhibitors inhibits acid. Anything that inhabits acid, including our gastrin antagonist, will increase gastrin levels. So if not to the same extent as the pernicious anemia patients, but it increases up to 5-fold. There are doctors who have staked their reputation on saying that that's harmful and there's going to be an epidemic of gastric neuroendocrine tumours and gastric cancers in the future. So far, there are just a mere handful, 2 or 3 case reports, and I have to say all the evidence is against proton pump inhibitors leading to these tumours. Now, as for Barrett's, that's another matter. The reflux of acid from the stomach into the esophagus in some people causes gastrin receptors to be expressed on the lower end of the esophagus, and reflux of acid is the main cause of Barrett's esophagus, as it's called. We are currently running a trial in the USA. We need 20 patients to see whether it's worth going on. We're up to 17. It's been hard work getting those 17 because they need regular gastroscopy. I should be able to tell you next year what gastrin does.